to everyone and welcome you all for this webinar on urethral stricture disease. Now, as far as treatment is considered, internal urethrotomies, some people prefer an urethral dilatation, some people prefer an injection, some people prefer an urethroplasty. That is the complexity of treatment because each one of us feel the treatment which we are offering is probably the ideal treatment that is available in our setup. The other thing is success. What is success in urethral stricture disease? No one really knows. Whether it's a patient satisfaction or it's a doctor satisfaction, the patient doesn't come back to you for a dilatation. Is that a success? Patient is doing a CIC. Is that a success? Or an objective radiological evidence is required? No one is very sure. This is one of the main reasons because of this complexity. Any urethral stricture disease conference or webinar, if you go in, everybody is interested and more numbers will log in. And today is not going to be an exception. I'll be failing in my duty if I don't thank Dr. Chandra Mohan because ever since he has taken over as a secretary of this association, there are two big advantages. One, he is academically interested and he is able to bring out a lot of webinars. Second, his connectivity is very good. This actually helps the ASU in putting this to much larger numbers. Thank you, Dr. Chandra Mohan, for all the help you have done to the ASU and continuing to do. I'll now hand over the proceedings to you so then you can introduce the theme as well as the moderators. Thank you.
Thank you very much, sir, for your kind words. It's my duty, in fact. To introduce today's topic, the primary focus is to cover all the subject related to urethral stricture disease in 2 hours. I know any big subject cannot be covered, but we will try to give as much message to the youngsters about the urethral stricture disease. So today our moderators are Dr. S. Bobby Vishwaroop, Dr. Rajesh Rajendran, and Dr. Bhavatej. To briefly introduce about them, Dr. S. Bobby Vishwaroop is a senior consultant uro-oncologist and andrologist, Vedanayagam Hospital, Coimbatore, education MCH, CMC, Vellore, experience 18 years, specialization uro-oncology, laparoscopy, endourology, uretroplasty, reconstructive surgeries. Rajesh Rajendran, reconstructive urologist, Aishwarya Hospital, Tiruchirappalli, senior assistant professor, KAPV Medical College, Tiruchirappalli, completed MCH urology in Stanley Medical College, various organized 10th ASU Professor HS Bhatt midterm, having invited in reconstructive urology faculty in national conferences. He has described ileal mucosal graft urethroplasty. The Dr. Bhavatej Iganti is another moderator who is having over 14 years of experience, and he is also DNB Research Program Coordinator. Presentations more than 100 in various national and international forums, around 35 academic awards and publications, conducted over 40 national and international live operative workshops. So he is member of various urology organizations of international and national standards. With this, I hand over the program to Dr. Bobby Vishwaroop, sir, and the other moderators to conduct the program. As you all know and aware, the speakers as well as the moderators, we will try to do the program within the stipulated time. And also the last speaker will be waiting for his turn. So please respect in relation to the time. Thank you.
Thanks, Secretary, sir. Good evening to everyone. At the outset, I thank the ASU and especially Dr. Chandra Mohan for giving me this opportunity to moderate this webinar. Most of what I wanted to say was actually was summarized by our President, Dr. Tengalur Ryan. Urethral strictures are one of the most common urological conditions. Everyone would have managed it either willingly or unwillingly, with their own success and failures. In this webinar, we look at recent advances to age-old dilatation and EAU, get a balanced view on surgical options in treatment of strictures at different locations. I request audience to post their questions in the chat box, and we'll take these questions with the expert panel at the end of the session. If time permits, we shall have few case discussions. To open the innings, I call upon Dr. Kannan Nayak, who is an alumnus of Kottayam Medical College. He completed his MBBS, MS, MCH from Kottayam Medical College, and he is a FRCS Urology Gold Medal in UK. Currently working as Clinical Associate Professor at Amrita Institute of Medical Science, Kochi. His areas of interest include endourology, functional neurourology, reconstructive urology, and andrology. Over to Dr. Kannan.
Thank you very much, sir. Shall I share my slides?
He is going to talk about Optilume, recent
Yes, sir.
advances in dilatation is on Optilume.
Is it visible, my slides?
Yes, please go ahead.
Yeah. Very good evening to all. First of all, let me thank the ASU for giving me this opportunity. Without much delay, I am going to my topic, which is Optilume. And Optilume is a drug-coated balloon, and that is recently launched, maybe in 2021, for the management of urethral strictures. We know that we are dealing with an age-old problem, but at the moment, we have definite options for this strictures. And we have a DVU as well as dilatations, and DVU and dilatations have a curative intent in the index cases, and we have definite guidelines how to go about with these dilatations. And whereas in recurrent strictures, it has only palliative intent. And urethroplasty is a curative options in recurrent strictures as well as in long strictures. It is a guideline from the British Association, and we have other societies also echoing in the same fashion. That means the DVU as well as dilatations are quite effective, and in the index case, whereas in redo cases, the urethroplasty is the gold standard. So at this point, there is a pertinent question: do endoscopic treatment work? So we have a landmark study by Hayes that has categorically stated that the stricture-free rate in both DVU as well as dilatation during the first procedure is around 50 to 60% in 48 months. And it is only a randomized control study that has been done so far. And we also have one seminal paper by Blandy that he looked into the fact that a urethroplasty, whether the urethroplasty's results can be comparable with a sachets urethrotomy, the DVU. This study has shown that at 5 years, the success rate of urethroplasty is around 83%, whereas the urethrotomy is around 50%. Now we have a recent data that is coming from the open trial. This is a superiority trial of endoscopic urethrotomy when comparing to the gold standard, that is open urethroplasty. But when you analyze the results, it is quite interesting to know that around 38% of the patients who had been randomized into the urethrotomy and 20% of the patients who was randomized into the urethroplasty had recurrence. So that means it is quite comparable. But we have to take it with a pinch of salt when you consider that self-dilatation was not considered as a reintervention. So this goes to another fact that we are quite familiar, and we are quite we think it's quite assuring in your practice. When we do dilatation after DVU, the results are better. And it has also been evaluated in a randomized trial that has shown if you do a DVU with dilatations, and the success rate at the end of 1 year is almost at par with that of a standard procedure, that is a urethroplasty. So this will amount to our one consideration that if we do some adjunctive procedure along with our endoscopic procedure, so that we can break that vicious restricture formation, we can actually improve our results. When you have some kind of an intimal damage, it's either be a primary injury or because of a dilatation, what happens is there will be recruitment of the inflammatory cells as well as increase in the proliferation of the fibroblast. It finally result in epidermal bulging and loss of epidermal elasticity, resulting in a stricture formation. So there have been so many attempts and so many studies that has evaluated the role of so many facts, so many manipulations to abort this vicious circle, but none has stood the test of time because of their own inadequacies. Now we have something called a true game-changing new kid in the block. It is called an Optilume. Optilume is basically a balloon that is coated with a cytotoxic material called paclitaxel, and it targets the microtubules and it acts as a mitotic inhibitor. And this particular drug will prevent the fibroblast proliferation and will prevent the restructure formation. Basically, This is a guidewire delivered inflatable balloon, and this inflatable balloon has a hydrophilic coating. This hydrophilic coating will facilitate the transfer of the drug from the balloon to the tissues. And the drug is the paclitaxel that will reduce the fibrosis, restenosis, as well as the scarring. This is a schematic representation of this balloon. This is almost as similar to our normal urethral dilatation balloon. The basic steps are: one is a mechanical dilatation. If the stricture is quite fibrotic, we need to have a pre-dilatation. After the dilatation, we deploy the balloon, and this balloon goes micro fissures that will facilitate the drug uptake. And once the drug is delivered, it will inhibit the cell division and inhibit the cell growth and prevent the recurrence rate. This is how the Optilume works. Paclitaxel is circumferentially derived in a precise manner, and this paclitaxel remains present throughout the inflammatory proliferation and remodeling stages of the wound healing and will prevent the stricture formation. And this is a short video I have taken from YouTube. So this will give us an idea how it works. Under fluoroscopy, we delineate the stricture. We pass a wire across the stricture, and then you deploy the balloon, and we keep the balloon at least for 5 minutes. The hydrophilic coating over the balloon will facilitate the delivery of paclitaxel into the microfissure that has been developed by the dilatation. And once this is done, we keep the balloon for 5 minutes, then we take the balloon out. And the drug will remain there at least for 28 days, so that the drug will facilitate the remodeling and prevent the restricture formation. So after the procedure, we have to keep a catheter for 4 to 5 days. Ideally, it is a 12 French catheter, and we should not do any other manipulation after the procedure because it can wash off the Optilume. And patients should be abstained from sexual activity. And if his partner is of a childbearing age, we ask them to go for protection at least for 90 days. That is a cytotoxic. We have a robust clinical evidence to support this. It is called robust study. Robust 1 and 2 are some observational studies, where under robust 3 study is a randomized multicenter trial that has been conducted in the United States and Canada. Here, the Optilume has been compared with the standard of care. Here, the standard of care is not a urethroplasty, but plain balloon dilatations or BVAU. And the results are quite promising. The studies have shown that the Optilume, the arm has fared well in IPSS score as well as in Qmax over the time. And the re-intervention rate also very less in the Optilume compared to the arm. So this is the summary. The freedom from re-intervention rate in the Optilumes is around 77%. And there is a reduction, there's an increase in Qmax by 176%, and the reduction in IPS by 67%. So it is actually a game changer in the management of the urethral strictures. So the side effect profiles are very negligible. Patients will have some kind of a dysuria and hematuria after the Optilume, so which is not that gruesome. So in this particular, we have an option here. So where do we place this option in our armamentarium on the management of urethral strictures? Is it a good case? Is it a good option for elderly, obese patients or patients who behave in not an unpredictable fashion? So now we have a recommendation also for the usage of Optilume in our current practice. The NICE guideline and the other guidelines have suggested that the Optilume is an option in the treatment of recurrent bulbar strictures in adult males, and it is not recommended for a primary index case. So summing up, so urethral stricture is quite prevalent and a costly disease, and we have Optilume here. And when you compare the Optilume data for the last 3 years, it seems.
Yeah, it's okay. You just summarize because I think they have automatically.
Optilume is a promising tool, the management of recurrent urethral strictures. Thank you.
Thanks, Dr. Kannan, for sticking to the time and giving a nice overview on Optilume. I call upon Dr. Sandeep Reddy, is one of the youngest on the group. He is a consultant in Yashoda Hospital, Somajiguda, to talk about GIU with intraurethral agents. Dr. Sandeep Reddy.
Yes, sir. Good evening, sir.
Please share your slides.
Good evening, everyone. I want to thank President Sir, Secretary Sir, and Dr. Surprakash Sir and Bhavya Sir for giving this opportunity. I'm audible, sir?
Yeah, please go ahead.
Yeah. Today's topic is my topic is VAU with intraurethral agents. Definition of stricture urethra. Stricture urethra is nothing but it's a spongiofibrosis where the fibrosis and secretration occurs of the urethral mucosa and the surrounding spongiosum tissue. In posterior urethra, we use the word stenosis. According to AAU classification, degree of urethral narrowing, anything less than 10 French is considered as flow significant strictures or high grade strictures. 11 to 15 French is considered as low grade strictures. Definition of VAU where we open the stricture by incising and transurethral. This procedure where we involve incising the scar tissue so that allow the scar to expand with the goal so that it heal with a larger caliber. So this process of incision sets off a race between epitheliation and wound contracture. So if the incised area epithelize heal by secondary intention before the wound contracture, then the area will stay open. If not, the stricture recurrent can recur. What is the role of VA in primary stricture disease? This landmark trial by Barbagley has clearly shown that best candidate to go for VAU are less than 2 centimeters single shot bulbar strictures. Even this study also clearly shows that if the number of attempts of VAU are done, stricture-free recurrence decreases, and even in the single attempt of VAU also over a period of 24 months of follow-up, stricture-free recurrence gradually decreases.
Yeah, I think so. I lost them now. Yeah.
What is the role of VAU?
I'm seeing that, sir. I'm trying to rectify. Please go ahead yourself. There is something written. I will try to remove it.
Okay, sir. What is the role of VAU for recurrent strictures? This trial where they compared randomized trial compared between the open urethroplasty and endoscopic urethrotomy for the recurrent bulbar stricture, it has clearly shown that urethroplasty has 2.64 higher odds of better Qmax at 24 months follow-up, and even the significant p-value in recurrence, low recurrence and reintervention rate in urethroplasty when compared to urethrotomy. What are the factors, predictive factors for urethral patency after VAU are? In Barbagley trial, it is clearly showed that up to 2 centimeters patency was very good, and as the length of the stricture increases, patency gradually decreases. And even the number of attempts of VAU, patency rate decreases.
Request, can you stop the sharing the screen and then restart, please, if you don't mind?
Okay.
We are trying to find out the problem and yeah, restart, please. Sorry for that.
Is it okay, sir, now?
Thank you. It's okay. Thank you.
Go ahead. Go ahead.
Sir. Even in the children also up to 2 centimeters, it is ideal to go for VAU, but more than 2 centimeters, stricture recurrence, it is very high. And even the VAU has performed poorly in the penile strictures. There is no role of VAU for penile strictures according to this trial. What is the role of lasers in VAU? This trial is a systemic review and meta-analysis trial where they studied 137 publication, and they clearly showed that at 6 months and 12 months follow-up, p-value was very significant. Recurrence rate was very low in laser when compared to the cold knife VAU. This study where they compared with 5-year follow-up between the whole mem laser versus cold knife laser. In the short term, IPP score, quality of life, Qmax are better with Holium, but long term, there was no much significance. So overall, lot of the studies compared, and because of similar complication between the cold knife and laser, available studies do not support any efficacy of one technique over the other. Role of intraurethral agents in stricture urethra. Previously, we used to, as adjuvant therapy post VAU, captopril used to use. It has much, in all the studies, it doesn't have any much significant role. No significant differences are noted in the flow rate and recurrence. Steroids. Tamsulosin, it has a very good results. A systemic review and meta-analysis done in 2014.
Sir, excuse me, sir. Please stop it, sir. Sir,
Sir,
somebody's
sir,
iPhone, they are writing something that is not correct.
Yeah. We are trying to rectify that.
I think somebody
Sir,
was
we'll
there
ask-
with iPhone.
Removing, sir.
Also, I think
We are trying to remove it.
This is some fellow who's scamming here and
Yeah, sir.
blogger.
Yeah,
Shall I stop screen and start again, sir?
Huh?
No point, it will come back again.
no, you take away your photo
Find out?
from there. Anyway, your
Yeah,
video
we
is
found
still-
him. We found him. We removed.
Okay.
iPhone, na?
Can I
The
share,
person
sir?
who has done is something Ranjit, some name. We have removed it. Sorry, Mr. Sandeep. Proceed, please.
Sir, I'm
Very
sharing
fast.
the screen.
You take your time, no problem. Yeah, please.
Can I see, sir?
Yeah,
Sir, this study is a systemic review meta-analysis trial, sir, where they compared the local steroid for after VAU with the where it will prolong the recurrence rate, time to recur, it will prolong it, but it doesn't have any significant role in overall reducing the recurrence, sir, and even adverse effect also. But still, with the good evidence, steroid can be used as a therapeutic adjuvant after VAU. Mitomycin, this systemic review and meta-analysis where they compared all the adjuvant post VIU, 13 randomized control trials were included, where they have shown that something is coming on the screen.
But he doesn't like you. God, this is
No. This is some scam which is happening.
Somebody is
Somebody
sick
has
guy.
hacked into the system.
Yeah.
To the system, whole system is corrupt. I don't think you'll be able to do it. Somebody's hacked into the system. You
It's
will have
not
to
the
get.
whole system. It's only one person is doing.
Yeah, but
The
somebody's
next
hacked into it.
presentation,
You will
let's
not
see
be
if it
able to
happens.
pull them.
Yes,
Go
sir.
to the next presentation, we'll get Sandeep back again.
Okay.
Let's see if it happens.
I think Sandeep will stop sharing now.
Okay, sir.
We can come back afterwards.
We are trying to
next-
stop that interference of writing. Just I am working with software team. Please bear with us. And we will proceed with the next presentation without wasting time.
Yeah.
Sorry.
So the theme is the distal penile urethral strictures, and nowadays there are new concepts of doing it from inlay as compared to the earlier onlay procedures. The most common procedure still today is Blandy myotoplasty. To enlighten us on the inlay technique, I call upon Dr. Bhautej. He is a consultant in Asian Institute of Nephro-Uro, Hyderabad. He is a DNB coordinator as well as a research coordinator, has more than 35 awards and publications to his credit. He is a dynamic organizer. I call upon Bhautej to talk upon inlay in distal penile strictures.
Thank you for the introduction, sir. Am I audible, sir?
Yes.
I'll be sharing my screen. Are my slides visible, sir?
Yes.
Yes. I will provide a brief insight into the management of distal penile strictures, focusing on various inlay techniques. Usually, distal penile strictures have varied etiology, usually associated with lichen sclerosis or post hypospadias or following instrumentation. Coming to some basics here and some technical implications. What is an inlay technique? Basically, when you do an inlay technique, is you place an autologous tissue in the urethral lumen, when compared to the non-lay technique where you place it on the lumen. The ideal tissues which we require for an inlay technique is always a free graft, because you can't place a flap into the lumen, so it will be a very difficult prospect. So I would be concentrating only on distal penile urethral strictures, which involve the external urethral meatus, fossa navicularis region, and the distal 1/3 of the penile urethra. There are various techniques involving management of distal penile strictures. It can be based on the etiology and the quality of the urethral plate. They can be either single stage or a staged approach. Most of the time it is a staged approach because the large recurrence of lichen sclerosis in our scenario. Single stage approaches, we have dorsal inlet techniques with or without gland splitting incision or a gland preservation techniques. The most common and well-versed inlay technique has been described and introduced by our own Professor Rasopa. And here, this technique is a dorsal inlay technique. Usually, it's ideal for strictures with a minimum urethral plate of 8 mm. It's a simple technique which wherein we can use a pupusal graft or a buccal graft. The technique usually involves a circumference incision or a ventral sagittal incision over the stricture region, followed by penile degloving. Here, the urethra is not mobilized much. So, following identification of the distal segment of the urethra or the stricture segment, we give a ventral sagittal incision. This is followed by identifying the urethral lumen. Then we give an incision in the urethral plate in the dorsal midline, and we place a graft on the dorsal inlay. So here we place a graft inlay, and then we close the urethra with either single or two sutures, and followed by a post-op placement of a catheter, which may range from 3 weeks to 4 weeks. And this is how Professor Asopa explained or described this technique. But over a period of time, when we see some strictures involving the more distal aspect where there is an intact glans, when you do this similar technique of a gland splitting incision, we may encounter few complications like a urethrocuteneous fistula or a glans dehiscence. Sometimes this may result in a deformed glans, and functionally it would be an undesirable splaying of urine.
Sorry to disturb you, but my name is Athar. I'm from the Zoom department. There has been a breach in this meeting link, and even though it may be a simple breach, but we have just gotten a lot of notifications that there is a high possibility of DDoS and hacking in this server. So I'm just
close and
yes,
start.
sir.
We are trying to rectify. This is the first time happening in June. Anyway, start, Bhavesh, please.
Yes, sir.
Short period of time, name is coming. If somebody can catch the name on that, please type it. Somebody, please. Thank you. You proceed, Bhavesh.
Can you see my slides, sir?
Share. You share the slides.
I think the problem is when they share the slides and not when he's speaking.
Sir, at the moment we are making the host only this person. We will try to only one host, that is who is speaker. Rest of all the things cannot do anything. Let's try like that.
Actually, the DDoS level it is pretty high, so you may need to what you have to do is
stop
exactly like you can see the meeting is getting graded. So please, if you can
No, sir. What they are telling is it is jeopardized beyond their control. That is what they are going to, they are conveying.
Some bingle, yeah, that's it. Yeah.
I muted when that person appeared to me. Proceed with Bhavesh, please. Bhavesh? You muted Bhavesh also? No. Bhavesh, unmute.
Yeah. Yes, sir. Can you see my slides?
Share.
1 minute, sir. 1 minute.
There's a message from Zoom.
Can you see my slides, sir?
Yes.
So when we do glans preservation techniques, sorry, we finished here. So to overcome these problems which we encounter, we actually plan glans preservation techniques. Basically, this prevents any urethrocuteneous fistula or can preserve the cosmosis with a controlled urinary stream. There are two techniques here which are involved. One is a transmural approach and a ventral approach.
Can you share? Sir. We made you co-host only you now. So sorry for the inconvenience. So that we can stop giving permission to everybody.
1 minute, sir.
Each person before they start will make the co-host. Then they only can do it.
Yes, sir. I'll just.
I'm trying with my level. Please bear with us.
Okay, sir. Right.
Sorry. Are you able to share now?
Just a
Sir, the message is coming from the Zoom department.
Yes.
That all our equipments can be hacked. Please do it after 30
No,
minutes
that is
like
not,
that.
that is not possible. Don't worry about that.
It is from the Zoom department. It is coming,
Sir,
sir.
everything comes like that only. Zoom will never send that.
तेरा लड्ड
Okay.
काट दूंगा वो सड़ी के तेरा वही लड़ना तेरी गांड में डाल दूंगा
See, Zoom department, I muted.
Remove them.
You can't.
Remove. Yeah, Zoom user, we muted actually. I'm removing now.
You'll come back again.
Yeah, yes.
Huh? We reported, no problem.
Ligma ball, sigma ball.
तुम्हारी माँ भोसड़ा रंडी उसके भोसड़ी के रंडी के मातर चोद रंडी के भोसड़ी
Sir, I think we have to go, sir. Nah, I think it is beyond control.
भोसड़ी के
Sir,
This will not work because this is beyond your control.
there is only one option, sir.
Cancel it for today.
No, sir. No, sir. We can give in 1 minute the new link. Because so many people are prepared, cancelling is not good. New link we can give so that we will not share to anybody. The
We will plan again. What's the problem? Don't worry, we are hacker.
Yeah, Secretary sir.
Yes, sir.
Is it possible to give a new link and then we decide on to accept whom?
Pardon, sir. New link and we will
New
give.
link and we decide on to accept whom?
No,
Acceptance.
sir, we have accepting.
No, please, no link. No.
They can join directly, sir.
Sauchi speak English. Sauchi Kannada, nigga.
No, please, no.
Mute all. So we'll make the new link quickly, sir, within 1 minute.
Okay.
Chandra Mohan sir, is it